Thanks everyone for being here today, for those joining us on site and online, and to my wonderful panelist colleagues for such very insightful discussions. Really, with the communities we work with, who are mainly migrants and Africans, the experiences of stigma and discrimination, particularly in clinical care settings, persist. A number of patients we work with routinely report being dismissed when they ask questions or they have concerns. There are cases of being treated differently. For example, being asked to wait in appointments so that they can be treated probably in more hygienic conditions. That's what they say. They're being told, or protective conditions, which means that HIV is a problem for most clinicians. And that is actually confirmed by a recent survey, I think, by Fast Track Cities, that looked at experiences of care patient experiences in primary care. It's staggering that a lot of clinicians don't have any knowledge about equals to you, for example, or that 40% of these clinicians surveyed from 3 London hospitals still felt that they can contract HIV by treating someone who's living with HIV. So I think that we need to be, what do we need to do as clinicians? I think that we need to first of all recognize that treatment, HIV care, is just not about adherence or putting somebody on treatment. For a lot of people we work with, there are a lot of issues in their lives: housing, poverty, migration. And I think even if you are communicating or doing your clinical duty, I think the question is also around the environment in which you're providing that support. Is your tone right? Are you mindful of this person's, other potential issues in life? We know very well that health ranks very low in the priority of people we work with, mainly because, there are life pressures. And recently, for example, we had a case of a young man who had a father who was dying at home. We diagnosed him with HIV. He was desperate to go back home and he could not. He wants an air ticket, but he's not working, he's undocumented. And so we were taking him for treatment. And when we accompanied him there, he didn't feel that he was treated very well. And the clinic had to come back to us. I think that first of all, we need to be able to appreciate, again, what community organizations such as ours provide, because I think that for a long time, a lot of clinicians, there's excellent work going on, and of course we appreciate our clinical colleagues who are working on HIV, but I think that if you look at general experiences in primary care, there's that lack of understanding, and I think that the role of organizations such as us who are providing support to patients should be appreciated and actually tapped, because there's an element of issues of trust. There's the issue around how people, perceive services. There are a lot of unconscious biases. 1 in 16 people have actually experienced discrimination and stigma in clinical settings amongst HIV patients, for example, in London. So I think I don't want to go too much. If there's any questions, you can ask, but I just think that, the issue of communication, the issue of being able to understand, have trauma-informed, perspectives when you're treating somebody, appreciating cultural, faith, and language barriers, looking at issues of immigration. We have a lot of hostility towards migrants, which is actually driving a lot of lots to follow-ups. So all these are very important, and we are here as community organizations. If you're not very sure, or you need additional support, we know times that are provided for patient care, quite limited consultations, but we have a lot of resources in the community, and I think some of these conversations, we can actually do them very well. So let's work together, and let's try and see that everyone has good experience of care in HIV.
Thank you, Denis. Last but by means no least to join the panel is Luca Stevenson from the European Sex Workers' Rights Alliance from Belgium. Luca is a male sex worker and operations officer at the European Sex Workers' Rights Alliance. Luca has worked extensively across Europe with sex workers from various backgrounds, including migrant and LGBT sex workers. He is also currently responsible for Mission for Jasmine, a project of Medicines du Monde France, which aims to address and reduce stigma and violence against sex workers, and sits on the board of directors of the global network of sex work projects in the and the Red Umbrella Fund. Welcome, Luca.
Thank you.
So Luca, while you settle down, I'd also like to invite you to just share your experience of stigma and how people should be communicated. I mean, how to communicate with in a non-judgmental way. I can't speak anymore. I was up at 3 a.m. In your area of work.
Well, thank you very much for having me and representing sex workers as well on this panel. Lots of things have been said. I think for us, sex workers, one of the main issues we're facing is that the first impact of stigma is we are seen as a monolithic identity. So if you think of like sex work, usually like the first idea you have is like, usually like a cis woman walking in the street, possibly using drugs, which do exist and are a big part of our community. But actually there are many, many forms of like sex work and identities within sex work. So we heard, from Rebecca and from others earlier that many different people work in the sex industry, whether they are like trans women, trans men as well, which are often like completely underrepresented, cis male sex workers, etc. And the needs vary as well. So I think like the first impact of stigma is like when you say you're sex work, you're definitely associated with like specific issues that might not be your issues. So I think there's a lot of work to be done. Like we were talking earlier about like, doing training for healthcare professionals. But I feel like one of the main issues is that you cannot really address stigma against marginalized communities if you don't do change at the structural and policy levels. So Vanessa was explaining at the beginning that stigma goes from like, internalized stigma to interpersonal to structural to policy level. And if you look at the situation in the UK, for example, in Scotland even, where I live in Scotland for many years, the definition of prostitution in Scotland is violence against women. And if you don't agree with this definition, you cannot access funding. So we had like a really good project led by sex workers doing services for sex workers in Scotland, and they lost their funding because they disagree with this definition, which is an extremely stigmatizing definition. Prostitution is not violence. Sex work is work and is recognized as work by the World Health Organization and by sex workers themselves. That doesn't mean there is no violence in the sex industry. There is a violence in the sex industry, and that's why we need to work in collaboration with sex workers in order to address some of the key issues we are facing. So for me, there can be a lot that can be done. There could be lots of training. I was really relating to like what Rebecca was saying, like, personally, I'm also extremely tired of telling my own stories. I'm sitting here, I'm like, yes, should I tell about like when I arrived in London and I was homeless and I was like, going to Homerton and, and there was actually lots of like really good relation with like, we talk like there's lots to be done, but already a lot is being done. Like we also have to like recognize that in the UK and many countries, there's already like a lot being done to address some of the stigmatizing attitudes. We're not like we were maybe like 40 years ago, still a lot needs to be done. But I think for us, like we can't really address stigma unless we address structural factors that impact our communities. So sure, let's do training with healthcare professionals to address the stigma against trans communities, against sex workers, against migrants, against people using drugs. But as long as like sex workers and other communities are not involved in the development of this training, are not supported, including with funding, then we're not going to have a long-term change. So my own personal thing, I wouldn't talk about my own experience of stigma. I can during the break if you want to hear some sad stories. But I think it's more important to like really reflect what can you do at your own level to make these changes happen. Because there is a global call for, from WHO, from UNAIDS, etc., to address like the structural issues. And what I'm talking is not just vague, like, I work now mostly at the European level, and currently at the European Parliament, there is a development of a prostitution report. Who is writing this report? Definitely not us. It's people who are committed to abolish prostitution through criminalization. So they are calling for more criminalization of sex work, which we know will increase the discrimination and stigma that we face. And that is not just theoretical. Like if you look in Ireland, for example, Ireland criminalized clients of sex workers in order to abolish prostitution. And this directly led to an increase of violence against sex workers, in particular most marginalized sex workers like trans sex workers and migrant sex workers. So we know there is a really clear link between legal frameworks, criminalization, stigma, and discrimination. And this needs to be addressed collectively. So my main point would be that, we do need, as sex workers, we need specific services. I think it's very important that each main cities and actually like rural areas have specific services for sex workers where sex workers can come and talk openly about some of the issues they face. Some sex workers want to stop sex work. Some sex workers want to get support in order to do it more safely. But in particular, what we need is like a general training and general addressing discrimination and stigma that sex workers face in all health services and HIV services. So it's both developing proper services in collaboration with the community, with sex workers as peer workers, etc., but also addressing stigma that, yes, as Rebecca was saying, so I keep saying Rebecca because I feel like we're relating a lot. You know, if a sex worker comes and say, I have a mental health issue, for example, the direct response from the mental health professional is not, oh, it's because of sex work. Like, that's one of the things that would happen to me. I would go to a service and be like, I'm dealing with anxiety, with like, you know, PTSD, for example, and the first answer would be like, oh, it's because you're selling sex. The easy answer is like, you have to stop selling sex. It's like, that doesn't answer any of my questions. What you need to address is like the, you know, quite intersecting issues that I'm dealing with as a sex worker, but also, you know, as a survivor of violence, as a migrant, as somebody who faces homelessness and mental health issues, which is much more complex than trying to find the easy solution, which is like, oh, the issue is sex work. Stop sex work and you'll be fine. Most of the time, people have very intersecting issues, and this is how we need to unpack and understand stigma and discrimination. Thank you.
Thank you.
Thank you, Luca. We've heard from a very diverse speakers, and we now have a chance to ask any of our speakers any questions. And we're now also open on the online forum, which I'm keeping an eye on. I mean, there's a lot of comments, very good comments from Rebecca's experience, from Joe's presentation, from everyone's presentation. Everyone's just saying, you know, the main issue is that the people we actually need to reach are unreachable, and how do we work on that? So the floor is open for questions. There's a question on microphone 1. Thank you, Jeff.
Yeah, good afternoon. Thank you for your speeches. I just want to ask, I don't know, any one of you can answer the question. We know that when HIV came out at the early stages, there was strong campaign, and that changed the mentality and the views, formed the views around people living with HIV, and that view still sustains up to today. But we've seen medication, treatment advances, we've seen U=U coming out, but that has not received the kind of publicity that occurred in the past. And that is the reason why stigma is still a problem. Because I think that if we begin to project a narrative of the advances in treatment and the efficacious nature of U=U, I think that would change the mentalities. So I don't know if there is any kind of strategy, you know, in a continental basis that would be able to project that narrative. Because if you ask someone on the street what is U=U, they don't know, but they have an historic understanding of what HIV is, and that has not changed. But yet there is advances within the HIV community and within the healthcare settings. We know all these advances, but people out there are not aware of it. And we're talking about stigma, fighting stigma. That means we're fighting it on a superficial level. If we need to fight it, then we have to project the message and let everybody become aware of it. And that's. I don't know if there's any kind of interventions in that area.
Who would like to go first?
I can say something. I agree with you totally, and because I'd say it was about 4 years ago when I was working at Terence Higgins Trust, and we used to do outreach in Soho. So we did certain different campaigns, and one of them, it was very in its early days, I think, if I'm right, U=U. And the guy I was working with kind of got the U=U slogan and campaign thing. I didn't get it as much, but then there was the Can't Pass It On campaign. And that kind of registered a lot more with me, that I was able to, going around bars, you know, like even saying to some girl, you know, that was at a bar, well, what does U=U mean? And then you say Can't Pass It On. And if you say Can't Pass It On, well, if you're HIV, you're on your medication, you're undetectable, and if you were pregnant, you can't pass it on to your unborn baby. That makes sense, and you can see the penny dropping with that. But, and I'm being quite honest here, for ages it took me a long time as well to kind of sell the U=U campaign, because I found it, for me, I don't know whether it's because I'm blonde, but I found it just tricky to get out there for some reason. And I do know that since that, a lot of people say, yeah, it sounds like it should be easy. And I think it's very catchphrasy and it works, it looks good. But I don't necessarily know that that message gets across as, to me, what the Can't Pass It On campaign does.
I will say, I think one thing that has been helpful, certainly for targeting the MSM community, is use of social media and also use of dating and sex hookup apps. So Grindr, we all love to hate it, but they have got a big thing about putting people's HIV status, and they have a little info button about what U=U is and how to get PrEP and links to more information. So how do we target people who aren't on these apps is the next big question. Perhaps, I mean, faith leaders, I think, targeting sort of the Black African religious and other religious communities. How do we get them on board?
Denis?
So that's a good question. I think personally, especially we have to start with the community of HIV. I just referred to a survey that was done where in 3 major London hospitals where 80% of clinical staff there did not know about U=U. I think we need to start from the basics, and I think Gary will talk about the work they're doing with the fast track cities, of which public awareness is one of them. But I was just speaking to one of our patients last time who is looking to date, and she was saying that she feels it's unfair for her, somebody who's living with HIV, to be the onus to be on her to prove that she's not infectious. And I think that this is something that we really need to change. I think the conversation needs to move from HIV patients and the HIV community to the general public. And how we get that is to use all tools available, really, whether it's our private social networks, our WhatsApp groups, our families. We need to talk about it.
Okay, we have 2 questions from the microphone. I see microphone 1 and then followed by microphone 2. Go ahead, sir.
Hi, I'm Glenn from Eyes Open. It's actually an area which we work in. We're responsible for 4 NHS trusts pulling together their sexual health campaigns. Last year we did a U=U campaign, and that followed up from a U=U campaign the year before. And of course we are now living in a society which is very celebrity led. In terms of statistics, 2 years ago, 50,000 people across 4 counties watched information related to U=U. We involved a celebrity last year from It's a Sin, and 2.3 million people clicked on our pages. Unfortunately, the funding side goes along with everything else, trying to justify to a funder that they should pay for a celebrity is pretty much a brick wall, and we find ourselves yet again now this year where we've had to delay our campaign for another year just so as we can try to source funding for that. On a separate note, can I just say, Joe, you're a breath of fresh air. I got diagnosed at the Kobler Centre 28 years ago, and it was a different world back then. In fact, I found out I was HIV 30 years ago when I was, I'd been treated for hepatitis, but I had to go along for the whole officialdom, and I couldn't cope with the stigma. I ran away from it. My whole life has been revolved around pride work. I've been the chair of many prides, but I've never tackled the subject of HIV. And it took the death of my doctor, Dr. Martin Fisher, rest in peace. What a brilliant man. He kept me alive all of these years. But it took his death for me to realize that it's not all doom and gloom, and that it's not all about the stigma, and that you can do good even from behind the scenes.
Thank you.
Thank you. Microphone 2.
Yeah.
Hello. Thank you for the presentations. My question to Joe is when you move into Scotland. I'm really excited by the U=U message, and I came to the party late because I was very much untransmittable is not a word in English. And I think after 2 years of COVID and untransmissible, it was really encouraging to hear Kevin Fenton, Professor Kevin Fenton, at yet another talk shop, say undetectable means uninfectious. I'd never heard someone so senior in the medical model, at senior level in public health, speak about an infectious. And there's been a whole range of reasons why that hasn't happened. I guess for me, can't pass it on. I've always found it really challenging, passing it on, getting it, catching it.
Yes.
Because the language suggests inequity. If I'm passing it to you, it means I've got more agency, you have to catch it. I think can't pass it on. Well, that means who can pass it on, then how do you pass it on? I think really the language about transmission and acquisition, people go, that's too complicated. Well, teach people. You know, we're dumbing down language to such an extent that the reading age of your average audience is 14. You know, I think after the COVID revolution, we've all been in the fridge for 2 years, people are very, very capable of using transmit and acquire viruses. I just think the language is much more equitable. So I really invite this fora to kind of adopt that as a mechanism going forward. The language of transmission and acquisition is equal, passed across an equal platform. Nobody's got more agency than somebody else. People do not transmit viruses maliciously for the most part. If they are, there's something going on with their psychology or mental health. So I really invite the language of acquisition and transmission to be more meaningfully considered.
Thank you, Alistair. I agree. Language is very important. Language is very important in everything that we do, and it needs to be considered and taught to everyone in the healthcare system. Microphone, please go on the microphone.
Thank you so much. I just want to add a comment to Joe's comment about faith work and faith communities. I lead on one of the Fast Track Cities project on faith works in London. And clearly there is a lot of discrimination and stigma in the faith communities. My experience on the project, when you talk to faith leaders about HIV, they will say, that's not my area. So what we've done right on, is integrating HIV and other conditions in the faith communities. So this is what we do. You go out, you tell a faith leader, people have HIV, people have diabetes, people have hypertension, and people have also had COVID. So we'd want to bring a service to the faith community, and it is a holistic approach to everything. And that way, we can then talk about sexual health and HIV. And clearly, because of the stigma associated with HIV, the service may not be received. But if you add it or you integrate something else, then everybody will come and receive the service. I'm happy to let you know that over 50% of the faith communities we've approached, just integrating HIV and other services, they've been able to open the door. And we know that a number of people who have so many conditions will run to their faith leaders. Many of us will not go to the hospital per se, but at one point, you want to go to your church. And many people congregate with others. So it is a very, very important aspect when we are addressing HIV, especially in the faith communities. Thank you so much.
Thank you.
Thank you.
Thank you.
I wanted to just add to that. Thank you so much for saying that. We talked about social media, we've talked about faith groups. I think kind of the overall summary of what I say is that there isn't one size fits all. We can, in Dean Street, we put up campaigns when it's Prep Awareness Week in GAY and in Heaven, and we have great responses in those communities. But that's really not everyone's communities. We need to be going into different spaces. We need to be going to faith groups. We saw in COVID when there was so much distrust in healthcare that people use leaders in different communities to get them to engage. If we're not actively going in those spaces, and we're just going in spaces that we know are familiar or convenient or we've had success in the past, we're just repeating the same thing again and again. And actually where we need to go is where people are invisible, people who aren't coming to see us, people who aren't coming to get tested, people who don't think that things are relevant to them. Rebecca mentioned a lady who was dating kind of in her 50s and thought, well, no, that's not something that's relevant to me. Why doesn't that person think it's relevant to them? It's relevant to everyone. And if we keep this as niche as just people who work in community groups and work in healthcare to do with HIV, not GPs, not other specialities in our colleagues, and they aren't saying the same thing as us, it won't change. So I think we just need to make sure that we're flexible and we're just thinking outside the box and not just doing our perspective, but asking people who aren't coming to our services, why not?
And I would like to say to it, I agree with that. And also as well, it's great that we're actually doing this here today and it's not World AIDS Day, you know, where we see an awful lot of stuff just done immediately coming up to World AIDS Day or around it. And I just think, like I always say to people, I live with HIV every day of the week, every day of the year, you know, and we do need to spread it out more. And I think that that's sometimes why we do get people kind of like still taboo to talk about it, because it's a bit like your birthday is once a year, you know what I mean? Christmas Day is once a year, and now almost like World AIDS Day kind of kicks off Christmas, you know. So we need to kind of get HIV, more of these going, more through the year and stuff like that, because I don't want to use the word normalizes, but maybe it needs to be normalized more, you know, that people see it not so much as a taboo, especially people in religious orders and community and people like that. I think we need to do more of it, you know what I mean? And I'm beginning to see it happen more every year, that we're doing it not just around World AIDS Day and the like. I think that's important.
Thank you, Rebecca. Any last words, Luca?
No, just maybe briefly, like we often talk about our communities as hard to reach, which, you know, for us seems a bit weird, because like we're right here, and like, you know, for sex workers, for example, our clients can find us so easily. So why is it easy for like our clients or the police to find us, but like health services find it much harder? And I think it is because of internalized stigma, and because we're simply not a priority. I feel like each of the key population, whether like trans community, MSM, people using drugs, and sex workers, you know, like without making a competition amongst our communities, like sex workers often feel like we are basically like not really important in this fight, partly because of internalized stigma. And I sometimes like stigma within like healthcare professionals or funders of governments, etc. But one of, like you were saying, for example, about Grindr, you know, sex workers, the majority of sex workers in the UK use one platform. I don't know if anyone knows it, that would out you as a sex worker or client or an ally. So most sex workers use this one platform. There might be like 80,000 sex workers there, but there's no intervention made with this platform to reach out to sex workers there. So Adult Work is a platform, in case you don't know, you can check it out. Like, you know, there's 80,000 sex workers like advertising there. Why is there no intervention done with this platform in order to reach sex workers? The issue is that this platform technically is criminalized. You know, like people who run this platform are third parties, they profit from prostitution, therefore they could be charged for third party, for pimping, under the same laws that are criminalizing anyone who profit from the sex industry. So for us, there is really like this intersection on how criminalization actually also act as an obstacle to outreach, to prevention, etc. So that's why for us it's really intertwined, this issue around like discrimination and criminalization. The same is like, you know, if Grindr was criminalized because they would act as like, you know, a third party, we wouldn't be able to like use and collaborate with them in order to do this outreach project. So for us, this is really important to like work in partnership with sex work communities in order to like bring this message forward and have this like community empowerment that is essential to address stigma. Thank you.
Thank you, Luca. Oh, there's a question from microphone 2.
Marielle Maya, Medical Director for Vivens Care. It's just a comment I would like to share with you, because when I was a student at hospital, we have that key expert completely engaged into HIV, spending all their time into it. The new generation at hospital, at least in France, at least in Paris, let's say that way, they are less and less engaged in HIV. HIV is not anymore a future option for them. They are much more involved in infectious disease in general, and HIV is simply part of it. And that's something I think, coming back to what you say about the role of the HCPs and the nurses, this community in adding stigma to the people. So we are having less and less young physicians interested in HIV, and now the proposition is not to have a department dedicated to HIV, but much more department dedicated to infectious disease in general. It was just a comment I wanted to share to you.
Thank you.
Yeah, I think that's really important, actually. So the UK and Ireland and Australia are unique in that we have a specified training pathway for genitourinary medicine So we do integrated sexual health, HIV, family planning and contraception. And as you say, most other places, including most of Europe, it's HIV is done by infectious disease, and then everything else is done by either primary care or sort of gynecology or dermatology. My favourite joke about this, what's the difference between infectious diseases and gum? ID is Doctors Without Borders, and gum is Doctors Without Boundaries. But because we have that kind of community activist, patient-centered approach, most of us are, serving the community that we belong to. I think we can, that model, I really like it because it provides better care, I would think, for our HIV cohort.
Thank you. We'll take one last question before our tea break so we can wrap up. Thank you. Microphone number 1.
Thank you, Katie Darling. I'm a consultant physician in Switzerland. I just wanted to pick up on something that Luca said, and also Joe, I think, talking about the medical profession being paternalistic. And it's one thing being on the ground and relating with the patient, but it's a completely different thing to give people a voice. And what I love about Dean Street, like Rebecca, I hear this with other people as well, that you walk into the clinic, you see a need, and then you roll up your sleeves and you run with it. And one thing that I've encountered in the medical profession is the lack of somebody within the community who can run with a particular project. And one of the big barriers is other doctors saying, oh no, you can't ask them because they've had a really difficult time. I think it'll be too much for them. And I would say, you don't know that it's going to be too much for them unless you invite them to take part. And in my experience, when there's been a particular project, asking somebody who on paper might not particularly want to be involved, or who's a little bit shy, or who just hasn't been given a voice, when you present that to them, I've not yet had somebody who doesn't actively want to take part. And so I'd say one aspect of paternalism in medicine is to remove the need to be the voice when actually the people from the community can be the voice themselves.
Okay. Thank you. I just want to acknowledge and thank all the speakers for this panel, and also acknowledge our virtual viewers. There have been very positive comments, people saying, Luca and Rebecca, keep sharing your stories to keep fighting stigma. You need to be seen, you need to be heard. And there's also a comment about U equals U, that it needs to start with people living with HIV so that we can be sure about what we're talking about. We know what we're talking about. So I think it's been a very engaging discussion amongst my talented panelists and speakers. So we now have a tea break of 20 minutes. So we need to be back at 10 past. Is it? Yeah, 10 past.
Thank you.